So I will end there and then go on to introduce the next speaker. So thank you. And our next speaker is Chris Lunt, and Chris is representing the third of the National Initiative Driver Projects. He's the CTO of all of us, and I believe from your CV you've been a technology executive for 20 years with vast experience in digital identity, social networks, information ontologies, and you've started multiple companies. So quite a CV, and is also an avid musician, writer and reader. So over to you, Chris.
Thank you. Okay, there we go. So there's a number of things that we're attempting to do at the NIH with the All of Us research program, and there's one in particular that I wanted to emphasize here today for this audience, which is the fact that we are trying to reach out to people who've been traditionally underrepresented in biomedical research, and a chance to bring greater equity to the treatment of people within the U.S. But to give the mission of the program as a starting point, the All of Us research program is a historic longitudinal effort to gather data from 1 million or more people living in the United States to accelerate research and improve health by taking into account individual differences in lifestyle, socioeconomics, environment, and biology. Researchers will uncover paths towards delivering precision medicine or individual prevention, treatment, and care for all of us. So we're not just a genetic study, although very much inspired. This is Francis Collins. This is his baby. And at the end of the Human Genome Project, this was something he's really started to formulate back then. But between then and now, he's also realized that beyond just sort of our capacity to read the genetics of people, we've made a lot of other advancements that should allow us to get a better way to understand people and their health. And so there are really three pillars that we're resting the program upon. First off is that we are considering ourselves to be a participant-driven program. We're very focused on making the people who in the past might have been called subjects to be participants in the research, and to bring 1 million or more people together from a very diverse audience to pull together the richest possible data set that we could get, and making that easy, safe to use from people's, say, privacy perspective, and also making it as free as possible. And finally, then to catalyze a robust ecosystem of researchers to be able to use that by providing both good access and good infrastructure to do the research. And so let me tell you where we're at now. We launched in 2015. But on May 6th, we actually opened up to allow anyone within the U.S. to be able to sign up as a participant in the program. We started in 7 locations around the country after a year-long beta test. We now have over 200 clinic sites up and running for people to be able to do the physical part of the protocol, to do the biosample collection and the physical measurements. We've added 75 more since the national launch. We have 110 participants at this point in the program who are somewhere in the process, with a full over 60,000 of them having completed the V1 protocol, and I'll run through what's in that protocol shortly. And we have our first curated data repository put together with over 10,000 electronic health records. I was rather shocked, happy, sad, that at this point we have the largest multi-site collection of EHR data in the U.S. that's ever been put together. And the good part is we've gotten there already, and the sad part is that it wasn't that many records to do that. We have a biobank, which is at Mayo. We already have 1.7 million biosample tubes. We aliquot as those come in of both blood and urine. And we have a mobile health partnership with Fitbit and some others, because that is going to be another part of the collection of our program, our wearables. And we also have a mood app that's in testing. And we are putting our research infrastructure in place for a launch in 2019. That is the hope. So for the first time, everyone here will be able to access our data for their own purposes. So let's get to that part about UBR, underrepresented in biomedical research. It is an emphasis of the program that we want to bring in a diverse audience that has not traditionally participated in medical research. And at this point, 49% of that 110,000, actually of the 60,000 people who've completed the full protocol, are people who have a race or ethnicity that has been traditionally underrepresented. 30% of the people would qualify as being income underrepresented. 23% by age, that all being people who are older. We have not yet started enrolling children, but are working on our plans to start to enroll children shortly. 10% by educational attainment, 10% people being sexual or gender minorities, 4% by geography. This is one where we need to do some catch up. We started very much on the East Coast and we're starting to spread through the rest of the country. And less than 1% being people who are intersex. I don't yet have data on disability, and we're also working on access to care as another aspect of people who've been underrepresented in the past. These numbers add up to more than 100 because there's some people obviously are in multiple categories at the same time. But altogether, 78% of the people participating in the program are people who have been traditionally underrepresented. Race is a particular interest, and so right now, about 50% of the people who've participating in the program are white, 18% black, about 17% Hispanic, 8% multi-ancestry, 3% Asian, about 2% American Indian or Alaska Native, and then there's some smaller categories after that. So we're pretty pleased that we've been able to get these people to join the program, which has been an effort. A lot of these communities have a traditional mistrust of efforts like this, and so we've worked very hard with community groups to try and build greater interest and trust in working with the NIH on this. So that V1 protocol that I mentioned earlier starts with just getting people enrolled, consented, and authorized for us to access their EHR, their electronic health records. In the U.S., not having a national system for that, we are having to deal with a variety of each hospital system having their own systems in place, but we've started to make some forward progress there. And our emphasis has been to do so through the participants, so that we are using the participants' HIPAA rights to access their own records as a way to get access to those records, rather than going institution to institution, which also allow us in the long term to get greater access to people who are in rural or frontier areas. We have those people fill out a set of, at this point, 5 surveys, and there are more surveys coming in. Right now, those surveys covering things like basics, family health history, and personal behaviors and habits. We take physical measurements for people when they do come in to have their biosamples collected, including right now blood pressure, BMI, heart rate, height, hip circumference, weight circumference, and weight. And then they provide their biosamples, which right now is blood and urine. In cases where we have problems getting the blood, we are taking saliva, and we are doing a pilot with doing saliva for people where we are not able to get access to them because they are in frontier areas. Those biosamples are all stored in our biobank. And finally, what we're working on now is starting to distribute wearables and allow digital apps as well. So Fitbit would be the first pilot in that regard, and that data would be included in the data sets that would be available to researchers. We just announced last week or 2 weeks ago our first Genome Centers Award. So we're giving $28.6 million US for 3 genome centers. One being the Baylor College of Medicine in Houston, Texas. They're also working with Johns Hopkins University and the University of Texas Health Science Center at Houston. The Broad Institute in Cambridge, Massachusetts, who are also working with Color Genomics and the Laboratory for Molecular Medicine at Partners Healthcare in Cambridge, Massachusetts. And finally, UW, the University of Washington in Seattle with the Northwest Genomics Center. We're very excited to get to this point in the program. We will be starting sequencing this spring, most likely, this coming spring. One of the other things that we're emphasizing, because we're emphasizing this being participant-driven, is the return of information to participants. And that's including all the information that we gather about them, which includes the return of genetic information. Since ours is a research rather than a clinical program, this is not typical. And so we're breaking some ground here. And we will be doing a funding announcement for getting a genetic counseling resource in place. That announcement will go out this year, and in 2019, we will actually start to return genetic results to research participants. We will be doing a 20,000 person pilot program in 2019. And in that program, we will be telling people if they have any of the ACMG 59 variants, their pharmacogenomics, and giving them access to raw data. At this point, we will not yet be doing ancestry and traits, but we will be working towards that, hopefully shortly after that. The research portal itself, which I'd mentioned should be launching in 2019, we have a research access policies committee in place to decide how we're providing access to that. It will be a 3-tier approach in terms of the data storage. We will have a public tier of data that is summarized and available to anybody to look at. A registered tier, which will require going through a code of conduct, some amount of training, and then you'll be identity proofed and allowed access to all of that data. All of that data obviously being ID stripped. And finally, a controlled tier for more sensitive data, which at this point would include all genetic data, would only be available to people who could demonstrate some sort of institutional relationship. And we'll be working in time, though, to make sure that this is something that is available to citizen scientists as well. It is a passport model. We are not requiring people to state each time they go in what it is that they're going to research, but rather that they are given access that is broad access for all research purposes, although they do have to note what their research purpose is, which is included as part of their profile on the system. And we will be developing policies on access to samples for people who want to request access to something that's in the biobank for their own use, and also for the capacity to reconnect with the participant. We are also developing procedures for citizen scientists to get access to the controlled tier, as I mentioned. And all of this data is protected by certificates of confidentiality. There was increased strength of this put under the 21st Century Cures Act, which was passed as part of our most recent funding. And that requires us, as bearers of this information, to protect that information in pretty much all cases, including for most cases of law enforcement. And so this is to try and help make sure that the participants participating feel that their data really and truly is kept protected and kept private as part of the study. The research portal will be coming out with both the data and tools. We'll be launching first, before that, a public data browser, which will give people a chance to see what data we are storing. And the research workspace is built on top of Jupyter Notebooks and also has a cohort builder, and will also provide connections directly to common access tools. We are not working on a federated model. All of our data is passed from the research hospitals that we are working with and other institutions and stored centrally. This was something that we felt, one, that we could do given sort of the structure in the U.S., but that would also allow a particular kind of research that would be harder when the overhead of the federated approach is added in. The initial research website was launched last month. You're seeing a screenshot of that there, which lays out some more details about all of this and what's coming. And so we will be going through our data cleaning and curation process, and all of that is going on right now. So we're testing out these tools, testing our data to make sure that we have a good process for both collecting and curating the data. And that's it. And so I rushed through it knowing that we didn't have a lot of time and everybody's probably tired of sitting here and listening to people talk. So I will yield my time back to the floor and take questions at the end.